Hi, and thank you very much for joining us. I'm Mohammed Bashir. I'm interviewing today a very renowned clinical scientist at an international level. Her name is Dr. Dianna Milewicz. She is President George Bush HW Chair of Cardiovascular Medicine, and she's the Director of the Division of Medical Genetics and Vice Chair of the Department of Internal Medicine at the University of Texas Health Science Center at Houston, Texas. Dianna, thank you very much for your time. It's an honor to talk to you today.
Thank you for inviting me.
My pleasure. I'm going to cut straight to the point. I've got many questions to ask, but we have limited time, obviously. My first question is aortic aneurysm a genetically triggered disease? How?
So we've been known for a long time that you could have an alteration in just a single gene in the genome and be strongly predisposed to thoracic aortic aneurysms and acute aortic dissections. And we knew that because of Marfan syndrome. We've known about Marfan syndrome since the 1890s, and the skeletal and ocular features were initially described, and then later, about the 1950s, they described the aneurysms and dissections in these patients and put the whole story together, and the fact that it was autosomal dominantly inherited, meaning that people with Marfan syndrome have one normal gene and one altered gene, and so therefore have a 50-50 chance of passing it on to their children. So we knew already from Marfan syndrome that you could have a genetically triggered aneurysm. And after finding the gene for Marfan syndrome, which is the FBN1 gene, we found that there were other people with inherited aneurysms that often looked like they had Marfan syndrome but did not. And it turns out that there's further genes that can predispose to this disease that are different than the FBN1 gene. And then finally, my work and Dr. Eleftheriadi's work went in and just asked patients that didn't have Marfan syndrome, did they have first-degree relatives that were affected also. And through that, we could determine that about up to 20% of the patients with thoracic aortic disease had a family history. And once again, typically it's inherited in an autosomal dominant manner. And these people don't have the syndromic features that allows them to be identified with this predisposition. So there's no way to pick them out from the general population. And there's where we really need to know the genes that predispose those people to disease, so we can trace the gene through the family, figure out who's at risk and who's not at risk in the family, and then take those people that are at risk and put them on a protocol to monitor the aorta, treat them with drugs that will slow the rate of growth of the aneurysm, and then ultimately send them to you surgeons to go in there and surgically repair the aorta to prevent the acute aortic dissections and the premature deaths and disability associated with that.
Beautiful, beautiful, overwhelming. How much, Dianna, in your own words, how much do we know about how genes dictate the progressive, or the progression, I should say, of aortic aneurysm to an aortic dissection?
Right. So this has actually been one of the interesting things that has emerged out of our work and others in this field on how the genes help predict that progression of aneurysms to dissection. So if you take a typical Marfan patient, you can watch the aorta grow, that aortic root aneurysm grow to 8 to 5.5 centimeters, and be pretty assured that there's a low risk of dissection in that individual. But some of these other genes, we know we can't watch it grow, and that there's a much higher risk for dissection with little to no or minimal enlargement of the aorta. So if you take some of the genes that are involve the TGF-beta pathway, signaling pathway, TGF-BR2 in particular, that is associated with Loeys-Dietz syndrome, those patients we have fairly good data that they are prone to dissection with just minimal enlargement of the aorta. So for those patients, we need to manage them differently than we do your typical Marfan patient. We need to be more aggressive about when to send them to the surgeons for surgical repair. And what we wrote into the treatment guidelines in the US was that they be repaired when they reach about 4.2 centimeters. And there's some discussion whether that should go down to 4. But that's kind of a, that difference between 4 and 4.2 is a little bit hazy, and we really want better markers, biomarkers or physical markers that'll tell us who's at risk for dissection. But we know with patients with TGFBR2 mutations that they need that early repair.
Great, thank you, Dianna. This is very informative. Could genetic testing be used to predict the natural history of patients' aorta? And how about the risk of other vascular diseases? What's your views on this?
So, as I already discussed, the gene will tell us when to do the surgical repair. And these are true for the Marfan gene, the FBN1. The lowest Deitch genes are those genes that are involved in TGF-beta signaling, TGFBR1, TGFBR2, SMAD3, and TGF-beta 2. And then it's also true for those genes where they're inherited in family with no syndromic features. So with those genes, we try to collect all the data that we can on the size of the aorta at the time of dissection with people that have that particular gene mutation, and then use that to really determine when to send them to surgery. And then we also know that the genes will predict what other vascular disease that person is at risk for. So with Marfan syndrome, there's a very low risk that those patients will go on, after having an aortic root aneurysm, that they'll go on to have intracranial aneurysms or iliac aneurysms and so on. But for those genes that involve the TGF-beta signaling or the lowest Deitch syndrome genes, those genes we know that they will go on to have aneurysms and dissections of other parts of the aorta. And branches off the aorta, and then the cerebral vascular circulation. So they basically have to have routine imaging from their head to their pelvis to check for aneurysms routinely. We know if you go in and surgically repair the aneurysms, they do well with that surgery, and that those aneurysms should be aggressively managed also. And then with one of the familial thoracic aortic disease genes, those genes with no syndromic features, and specifically for the gene ACTA2, which is the major gene for familial thoracic aortic disease, those patients have a risk for ascending aneurysms and dissections, but they also have a risk for occlusion of the arteries, the small to medium-sized arteries, and that leads them to have an increased risk for ischemic strokes and early onset coronary artery disease, and even occlusion of the brachial arteries and other arteries. So, and it's really interesting to me biologically that you could have one gene that causes enlargement of the aorta, but at the same time causes occlusion of other smaller arteries in the elsewhere, and we're working on trying to understand how one gene can trigger both, enlargement and occlusion of arteries.
Great. So you're working on establishing an evidence for that. Any lights that you might want to shed on why do you think in your own experience that this is probably happening?
Well, we're working on a hypothesis that the mutations in the large artery, like the aorta, cause the smooth muscle cells in the wall of the aorta not to contract properly, and that leads to the aneurysms. But in the smaller arteries, for some reason, when you mutate ACTA2, which encodes for a smooth muscle contractile protein, alpha-actin, we have data to say that that leads to excessive proliferation of the smooth muscle cells. So when you have these mutations, suddenly the smooth muscle cells, if there's vascular injury, proliferate out of control and actually occlude the artery. And when you look at the arteries, it looks like they have little tumors of smooth muscle, benign tumors of smooth muscle cells in them. And so we think we can actually repurpose cancer drugs to prevent that occlusive disease in the patients. And we've done that in a mouse model. So we hope to have therapy for both the aneurysms and the occlusive vascular disease in those patients.
I want to take something out of the drugs that has been, I heard your presentation. It was an excellent presentation yesterday and a talk. And you mentioned something about Losartan and atenolol. And I've asked Dr. John Alfitriadis about this similar questions, which is, where are we now with Losartan and atenolol? What's your comments on that?
So I think the clinical trials are saying that Losartan works as well as beta blockers in slowing the rate of growth. Yeah. I know that Dr. Alfitriadis feels that the data for beta adrenergic blocking agents and their role in slowing the growth of aneurysms is not that good. Yeah. But there has been a published trial showing it does decrease the rate of growth, and that wasn't a blinded a clinical trial, but it's good evidence that it decreases the rate of growth. And therefore, I think you can use either agent, but I still think beta blockers would be the first line therapy because we've used them for a long time and we know that they're safe. One concern about the clinical trials is that the event rate, defined as dissection, surgical repair, or death, seems to be consistently higher on the Losartan arm than on the atenolol arm in the studies worldwide. And the studies, because those events are so rare, the difference hasn't reached statistical significance. But there's a planned meta-analysis of all the data worldwide, and we'll see if that does reach significance and would imply that Losartan would increase the risk for those other events. And so I still say we have a long history of using beta blockers, and we should continue to use them. Right. We know clinically that the two major triggers for thoracic aortic aneurysms and dissections are what genes you have and what pressures you have on the aorta. So the major risk factor for a thoracic aortic disease is hypertension. Yeah. And anything that drives increased blood pressure and biomechanical forces on the aorta increase those risks. And so it makes sense to use beta blockers because it decreases the force of the heart and the number of the times the heart beats. So you're just decreasing the forces.
Is there any link between the genetics that predisposes to aortic aneurysm and the biomechanical forces on the aorta, or the do you think that there is any link in between them, or they're two separate sciences? Because surely there are bioengineers, they talk a lot about the bioengineering aspects of an aortic aneurysm, but at the same time we know fundamentally that there are some genetic molecular things happening to an aortic aneurysm. What's your comment on a link in between them? Have we established any evidence of that?
So we're working on that, and the genes are telling us that the way the smooth muscle cell responds to those biomechanical forces may drive the disease. So many of the genes that we've identified for familial thoracic aortic disease actually affect the ability of the smooth muscle cell to respond to pulse pressure. Yeah. So every time the heart beats and that blood goes up the ascending aorta, the smooth muscle cells in the aorta contract in response to that pulse pressure. Now, in the aorta, the sort of recoil of the aorta is determined by the elastic in the aorta. So if you go in and poison the smooth muscle cells so they can't contract, the elastin in the aorta allows the aorta to recoil just fine. So the question was, what are the smooth muscle cells doing there? And obviously, by the fact that we're disrupting the ability of the with the mutant genes disrupt the ability of the smooth muscle cells to contract in response to the forces. It's telling us that those forces and how those smooth muscle cells respond are important in preventing the disease. So, and actually provides a link between the genes and the major environmental risk factor, the hypertension, because in the case of like the ACTA2 mutations where you're disrupting the smooth muscle specific isoform of alpha-actin, the smooth muscle cells are not contracting properly, but the pressures aren't increased. But in hypertension, suddenly the pressures are increased and the smooth muscle cell is trying to respond to increased pressures and may be upregulating the same pathways leading to the disease. So we're working on animal models to really test that hypothesis.
Right. What does the future hold? Any gene therapy might be, any blood test that can say Mr. X, Mrs. X has got a predilection for an aneurysm and for us to operate on an early basis. Any sequencing information, any genomic engineering that you might want to share with us?
Okay.
What's your perspective?
I'm not planning to play God and go in and do genomic engineering,
what's your
I know to that. Right now, we know in families with a predisposition or in people with early onset disease, like under the age of 50, that they really should be checked for the genes that we know predispose to that. And right now, we can draw blood or have them spit into a tube and be able to take the DNA and test all the known genes at once, from the Marfan gene all the way to ACTA2. And about 25% or 30% of the people, we can find a mutation in one of those genes. So we don't have all the genes, and we're working actively to find those genes. And the reason that I've really devoted a lot of my career to finding the genes is once we know the gene, it provides such powerful information. We can trace the gene through the family and figure out who's at risk and prevent those premature tests like I talked about. It tells us how to manage the people, that the timing of surgery, the risk for other vascular diseases, and really the goal is to get ahead of the disease so that once again we can prevent deaths and disability due to the condition. So we continue to identify new genes. We have two new genes that just got published and two more that have been submitted for publication. And the rate that we're finding new genes has been picked up dramatically because we can now look throughout the genome through whole exome and whole genome sequencing and it's much more efficient to identify the defective genes. And really the critical factor is for us is getting those families and patients participating in our research. And our research program recruits families worldwide, and the larger the family, the more power we have to find a novel gene in that family. So I'm incredibly grateful to physicians and patients who come and participate in our research, and please continue to send those families our way. And ultimately, we've been working on trying to understand the genetic predisposition for those people that don't have a family history and have your typical age of onset in their mid-60s. And what's interesting is some of the genes that we've identified for inherited predispositions, also different changes in those genes predispose people in the general population to this disease. So ultimately, I'm hoping we can identify the familial genes and the population-based genes and use that information to really identify who's at risk in the population. But we still need better biomarkers, and that's where some of Dr. Eleftheriadi's work and others have really helped a lot to begin to move in that direction.
Great. That's been very, very informative to me, and I'm sure to all the viewers and whoever is listening to this. I thank you very much for your time. It's an honor again
thank you for inviting
to do this interview.
me.
My pleasure. Thank you very much.
Thank you.
Thank you.